Thank you. Hello, everyone. Thank you for the invitation and for joining me. I'm Angela Zedda, a consultant from the University Heart Center in Dresden, in Germany. And today I'm talking about the left atrial isolation plus appendage occlusion, a novel ablation strategy for the patient with atrial fibrillation and end-stage left atrial fibrotic disease. I have nothing to declare. And I will start, one moment. I will start with a clinical case. Here I present a 79-year-old man with a highly symptomatic persistent atrial fibrillation that already underwent a PVI and substrate modification a few years earlier. Nevertheless, he experienced atrial fibrillation recurrences despite another treatment. So he presented in our department with a willingness to another ablation attempt. As in this case, we perform in every, one moment, please. Okay, there's something wrong. Okay. Sorry. Okay, perfect. As in this case, we perform in every ablation for atrial fibrillation 3D voltage map with the 3D mapping systems. And here are depicted the 3D reconstruction of the left atrial of these patients. And there are extensive low voltage areas colored in gray, representing a fibrotic disrupted myocardium. So this patient had an advanced fibrotic left atrial cardiomyopathy. We know from the previous studies that atrial fibrosis plays an important role in the genesis of atrial fibrillation through different mechanisms, not yet fully understood. But we know that it promotes micro-reentry, local automaticity that trigger and maintain atrial fibrillation. And we also know that there is a correlation between the reduced electrogram amplitudes recorded during the invasive voltage maps and left atrial fibrosis that we can see in histological studies. What we also know is that the extent of low voltage zone is an independent risk factor for atrial fibrillation, also after a PVI alone. So in this patient, what can we do to obtain a better outcome? As we can see from the study of the Leipzig group, adding to the MER PVI substrate modification could result in a better outcome in terms of AF recurrences in the midterm. But what is the substrate modification? Here I have listed the main procedure that we perform in our center. That is that we can the goal of these strategies are always the same. That is isolate, confine the low voltage zone from the healthy myocardium of the left atrium. And this is achievable through a local regional ablation or through linear ablation lines between anatomical obstacles to isolate these low voltage zones. So, and unfortunately, we know that a very important detail of this substrate modification is how extensive are these low voltage areas. Yamaguchi in 2018 well described this problem. Patients that had more than 30% of low voltage zone in the left atrium had a very poor outcome in comparison to patients that had smaller areas. So what can we do in these patients if also low voltage zone modification could not help besides the PVI ablation? For example, in this patient, if we have to think about a substrate modification, we have to deploy different ablation lines with extensive ablation, and this could be challenged without compromising the left atrial systolic transport function, as well as diastolic function, and of course the thromboembolic risk of this patient. An alternative already existed. In the 90s, emerged a few small studies of an attempt of surgical cut of the left atrium from the right atrium, with a good outcome in terms of recurrences. And this was an attempt only for atrial fibrillation, not only for atrial fibrillation, but also for supraventricular tachycardia, mostly accessory pathway. But the outcomes result in a lower rate of recurrences. So we decided to attempt this strategy percutaneously. We tried on a left atrial isolation, and we tested whether this strategy followed by the left atrial appendage occlusion could result in better outcome in terms of control of the rhythm and control of the thromboembolic risk. In the next part of the presentation, I would like to focus on three main topics: how to achieve a left atrial isolation, how to manage the stroke risk, the thromboembolic risk in this patient, and the hemodynamic changes that could be after the left atrial isolation. The first point, the ablation strategy. As we can see here below, we have the main interatrial connections between the right and the left atrium. The Bachmann's bundle is the main pathway for the activation of the left atrium, but we also have connection in the coronary sinus and around the fossa valis in the septum. So we try with our ablation strategy, with our ablation technique, to disconnect the left atrium from the right atrium through mainly two lines: an anterior line, including the Bachmann bundles, from the right superior pulmonary vein to the mitral annulus, and if needed, we can also deploy the line from an epicardial axis, and then also a paraseptal line from the right inferior pulmonary vein to the mitral annulus. In this case, is also needed an ablation from the right side in and around the coronary sinus. In some patients, it also needed a right pulmonary vein isolation or re-isolation if was already done. What can we expect from a left atrial isolation? Is a dissociation between the right and the left atrial signals. In this figure, we have an ablation, and we can see that the left atrial signals, indicated by the blue arrows, gradually split from the right atrial signals, indicated from the yellow arrows. After isolation in the left atrium, we can see a complete asystole, a slow rate intrinsic rhythm, as well as atrial fibrillation, atrial flutter, while in the right atrium a sinus rhythm is maintained. From the second point, the stroke risk management is always a very important point, and implies a very high concern for this patient, because we have an atrial standstill besides a fibrotic atrial myopathy. So in all this patient is a left atrial appendage occlusion mandatory. If the occlusion is not performed during the ablation procedure, a triple therapy or at least dual therapy according to the bleeding risk is could be safe and efficient as bridge to the left atrial appendage occlusion. In our center, we tested the very first 92 patients that received this new ablation technique. We conducted a prospective non-randomized study between February 2016 and February 2020. We enrolled a patient with highly symptomatic paroxysmal or persistent atrial fibrillation or left atrial tachycardia, and that with previously unaffected antiarrhythmic drug, that demonstrating in the voltage map more than 3 regions affected from fibrosis, with a mandatory involvement of the anterior and paraseptal regions. Our endpoints were freedom from atrial arrhythmia without and with antiarrhythmic drugs in the follow-up checks, and of course also complication rate, procedural data, and then the clinical endpoints such as NIA and NIRA classes. Here depicted the baseline patient's characteristic. As we expected, the mean age were older at normal atrial fibrillation patients, 71 years old, mostly female gender, and mostly with persistent atrial fibrillation. As we can see, we can also have a population. We had also a population with a high thromboembolic risk. Chadva score medium was 4, and highly symptomatic. ERA score medium 3. Then here I reported the main bipolar voltage map characteristics. To analyze the voltage map, we divided the left atrium in 5 main regions: the anterior, posterior, lateral, inferior, septal wall, and every region was further divided in 9 segments. And as we can see, on average, the percentage of low voltage zone was more than 40% in the left atrium, with a major involvement of the anterior, septal, and posterior wall. The rhythm outcome demonstrated that our technique was efficient. At 12 months follow-up, we observed that 78% of the patients were free from atrial recurrences, atrial fibrillation recurrences without antiarrhythmic drugs. We have also a good follow-up with an implanted devices in more than 80% of the patients, and only in 12 patients we have to perform a reduction of the CS, mostly because of reconnection. From the clinical point of view, we observed also an improvement of the symptoms immediately after the left atrial isolation, as well as the follow-up check. And from here depicted also the complication rate that also were relatively low. A stroke was occurred in the pilot phase of this study. The patient was not on triple therapy and was between the left atrial isolation and the left atrial appendage occlusion. So after this event, after the patient number 3, we decided to establish in every patient a triple therapy until the left atrial appendage occlusion. And we check also the hemodynamic changes after the left atrial isolation. Previous study demonstrated that after extensive left atrial ablation and in the presence of atrial cardiomyopathy, the diastolic function as well as the systolic function of the left atrium could be affected, the so-called stiff left atrial syndrome. So we checked over this problem was an issue also in these patients. We analyzed the first 20 patients with an invasive measures during the procedure, and after that also at the left atrial appendage occlusion procedure, the right atrial pulmonary artery and left atrial pressure, but we didn't demonstrated significant changes after the ablation. So in conclusion, we demonstrated that the isolation of the left atrium percutaneously is feasible, as be done by surgeons, so can be done as also by us, and it offers an effective treatment option alternative as a substrate ablation and also a patient ablate strategy in patients with an end-stage fibrotic atrial disease. Of course, the thromboembolic risk remain one of the major issue, and left atrial appendage occlusion is mandatory with a double or triple antithrombotic treatment if necessary as bridging therapy. Thank you for your attention. If you have any comments or question, I'd be happy to hear them.